This is postpartum 2. I'm going to finish up this PowerPoint. I forgot to plug in my computer to electricity, so it just cut out on me. So we talked a little bit about the importance of resuming sexual intercourse on a normal veg delivery within probably 4 to 6 weeks, but some type of birth control needs to be discussed prior to discharge so that they don't get an unexpected pregnancy within the next year. Again, if you are not breastfeeding, you can ovulate within within a month. So therefore, it's really important to be on birth control. With the prolactin and breastfeeding, most women, if they're solely breastfeeding, may not ovulate, but there's no guarantee. So again, birth control topic needs to be done prior to discharge. Episiotomy is when the doctor actually makes an incision into the perineal, or the nurse midwife into the perineal area. It could be a median, which is straight down, or to the side. Again, evidence-based practice tells us that it may be better to let the woman tear, and it doesn't necessarily. They used to do episiotomies because they thought it was easier to heal because it was a clean cut. Not necessarily true. Sometimes you'll tear less than you would actually if you were cut. So therefore, we don't see too many episiotomies. The degree is how far it goes. First degree is just a little tear. Second degree, third degree, fourth degree, would actually goes into the rectum, and it's a pretty intensive repair. Sometimes can cause some bladder and bowel issues later on and require some additional surgery. So again, when we talk about postpartum care and the postpartum period, the worse the tear or episiotomy is, probably the more ice, and they may need even medication to keep their pain level down at the perineal area, down below 4. Again, any laceration or a episiotomy, a first degree, just involves a perineal skin and some vaginal mucous membrane. The fourth degree actually extends into the rectal mucosa to expose the lumen of the rectum, and the others are in between. Again, depending on the degree, would be depending also on the discomfort of your patient and how much you need to pay attention to ice, the spray, the Epifoam, and just keeping her comfortable, sometimes with pain medication. The perineum will be swollen, regardless whether they've had an episiotomy or not. A baby just came out of there, but we also pay attention not only to the swelling and lacerations and episiotomy, but also the development of hematomas, which can be very painful, hemorrhoids, good hygiene to prevent infection, and nursing interventions, which we kind of talked about in the bubble he, as well as far as the spray and the Epifoam, the witch hazel goes. We talked a little bit about placental hormones. Again, the estrogen and progesterone levels that were necessary during pregnancy now have decreased with the delivery of the placenta, and the more hormones that take over now are mainly the prolactin, which has to do with the milk supply, and also the oxytocin, which has to do with the letdown of the milk, and also the uterine contractions to keep the woman from bleeding. Again, ovulation can occur in 27 days in a non-lactating woman. So again, and in breastfeeding, the prolactin can actually suppress ovulation, but there's no guarantee. Therefore, some kind of birth control would be necessary unless they want to keep us in business. The making of milk, basically after birth, again, the placenta comes out. There's a fall in estrogen and progesterone. The prolactin levels increase. The more the baby sucks, the more milk that the woman will make for her baby. So prolactin is produced in response to the baby drinking and emptying the breasts. Oxytocin is also essential to lactation, as in addition to the contraction of the uterus to constrict blood vessels, but it also is responsible for the letdown reflex. The abdominal muscles, it takes about 6 weeks for the abdomen to go back to its pre-pregnancy state. Most of the time they will. Sometimes if they've been overextended with triplets or a really large baby, sometimes the muscles still will protrude a little bit and postpartum for a while. The urinary system basically returns to the non-pregnant state within 2 to 8 weeks. Again, we always check for signs of bladder distension. If it's above the uterus and to the side, we need to make sure that mom keeps her bladder empty. And if she's had an epidural, we need to, or having difficulty, we need to assist maybe with a straight cath initially. So yes. In the postpartum period, they've retained a lot of fluids during the birthing process and pregnancy, and women begin to lose that excess of tissue fluid within 12 hours, particularly if they've had a lot of IV fluids. So they will begin to diurese, and sometimes they will even have like periods of sweating, and then they get chilled because of their body is so cold from the sweating. It's just a way of body getting rid of extra fluid. Sometimes there's trauma to the urethra and bladder during birth, and the bladder may become a little bit edematous. Sometimes it's difficult for that first void, but the bladder tone usually is restored within 5 to 7 days after birth, and most of the time, women after their first void, it gets a little bit easier after that. The appetite increases after delivery. Most women are on clear liquids when they're in labor. So they are really hungry by the time they deliver, and so you give them whatever they want. It's like the feast after delivery. After they're full and everything else, you may talk about nutrition, the importance of eating well for recovery and also for breastfeeding. The extra 500 calories, but it needs to be lean proteins, fruits, vegetables, and water. We know that sometimes they may not have a bowel movement for 2 to 3 days. Therefore, it's really important to drink plenty of fluids, high fiber, and take your Colace. We already talked a lot about the breasts and the engorgement when the milk comes in. And the best thing to do for that is to basically feed your baby to get rid of the engorgement. But also you can hand express milk. You can get in the shower. Or you can actually use a pump if you need to decrease some of that distension. The average blood loss for vaginal delivery is 3 to 500 milliliters. For C-section, it's 500 to 1,000. Anything greater than that could be a sign of postpartum hemorrhage. So basically, the vital signs are going to be pretty much the same right after delivery. Sometimes you might see some orthostatic hypotension. Coagulation factors increase the patient's risk for thromboembolism, which we talked a little bit about. Some women get some varicose veins in the legs, some spider veins. Sometimes those shrink, but they don't actually go away. We check their CBC when they first come into labor. We check it again postpartum just to make sure that they're okay prior to going home. Women come in with an elevated WBC, which is normal in our pregnant women. Headaches sometimes can be due to lack of coffee, could be hunger, whatever. But we do take a careful assessment when we talk about preeclampsia. Headache is one of the signs. In addition to that, a spinal headache as well. So we just assess the cause of the headache on our patients. Most of the time, the joints will be stabilized within 6 to 8 weeks. Usually that last month of pregnancy, the joints, everything kind of loosens up, preparation for the delivery, and then they stabilize 6 to 8 weeks postpartum. Some people may notice a permanent increase in shoe size. You may notice that your parents, your mom says that her foot grew with pregnancy. There is some truth to that because they relax and the joints and the ligaments kind of increase and the shoe size as well. So you might want to believe what your mom tells you. We're going to take out some look at some pictures on some of the changes that occur in pregnancy and those that go back to normal and maybe those that are a little bit different. Due to the hormone loss, a lot of women sometimes will notice they're losing their hair. During pregnancy, they may have noticed that their hair looked really good because of the prenatal vitamins and the hormones. Don't worry if they lose a little bit of hair afterwards. It's totally normal due to the hormonal changes. We already talked about the diaphoresis that may occur as well. Let's take a look at some of these other ones that we're talking about on the skin. This is chloasma. It's due to increased pigmentation during the pregnancy, and that will go away after pregnancy. Stretch marks, due to everybody's skin is a little bit different. Some people are more prone for stretch marks. Those with twins or a large baby are a little bit more prone. They decrease in redness and in width, but they are kind of a constant reminder of it's kind of your medal of honor for going into labor. Sometimes they fade, but they don't go totally away. Look at them as stripes of honor. There's linea nigra, which is that little strip. It's pigmentation. Some women have that even when they're not pregnant, but if they get it when they're pregnant, it'll probably fade or go away. But again, some women have it anyway, and it's totally normal. The immune system, when you're pregnant, your immune system kind of is decreased a little bit so that you don't attack the baby. There's the immune system will, kick right back up after pretty much delivery. And it's interesting. So when we do lab work, we always check for rubella, German measles. We came up with the vaccination in 1968. Most everybody has had it, but if they come up non-immune, right before they go home or discharged from the hospital, if they're non-immune, we will give them a rubella shot. And the reason being is because we cannot give it to them during pregnancy because it's a live virus. So we'll give it to them right after just before they go home for discharge. We'll talk about RH factor when we talk about the newborn. We already talked about discussing sexual activity with the patient prior to discharge and whether they go birth control or some type of contraception. That's between them and their midwife and their physician, but it does need to be discussed. Sometimes there's a reduction in the intensity of the sexual response for 3 months to a year that needs to be talked about. And know that it's totally normal. Sometimes it's due to the hormonal changes or some of the effects of, sometimes if people have had a traumatic birth as well, it could affect their sexual response. If you've had a normal bachelor, it's usually safe within 4 to 6 weeks to resume sexual intercourse. A C-section, of course, is major abdominal surgery, so most people aren't going to be feeling well until at least 6 weeks. If they were using a diaphragm prior to delivery, it needs to be refitted at the 6-week visit. They usually will not place an IUD until about 6 weeks at postpartum. And sometimes we have to watch which contraceptives they get if they're breastfeeding as well. Temporary contraception could be the use of condoms or mostly that, until the 6 weeks visits. Non-lactating women sometimes will get birth control pills on discharge if they're not going to be breastfeeding. Here, when a woman goes home, she has her witch hazel pads, which help decrease the swelling and promote healing. This is the Dermoplast spray that actually numbs the area. This is the Peri bottle that you will fill with lukewarm water and spray front to back to clean the perineal area, at least for the first 1 to 2 weeks after delivery. And these are the pads. So this is a normal bathroom appearance of somebody postpartum at home. A lot of discharge teaching goes along with it. Sometimes they have prescriptions that they need to take. Activity restrictions. Usually if they're C-sections, it's just advanced as tolerated as surgery. Most women, if they've delivered vaginally with no complications, feel actually pretty good and resume activities rather, normal daily activities pretty rapidly. Of course, if they're runners or whatever, we ask them to take it easy until, it takes 4 to 6 weeks for that pre-pregnancy state to be totally normal. Sometimes if they're breastfeeding, sometimes babies react to milk products or spicy foods, and we just have patients pay attention to that. And of course, we educate them. We've already talked about on lochia, headache, dizziness, those types of things. Anything to be alarmed about. Again, we'll give them the MMR if they're non-immune. We give them a Tdap if necessary for pertussis. Most babies will get pertussis from their parents or caregivers. So a lot of times our pregnant patients will get that. So they don't give it to their babies. Anybody who's taking care of the baby needs to get a pertussis shot so that the baby does not get it. Babies will eventually get their shots, but for pertussis, their immunity they won't get their shots until a little bit later on in their infancy. Flu shots are given to women during pregnancy, and that's because we don't want them to get the flu when they're pregnant because they can get really sick. And we'll talk about Rogan at another time. A lot of women too, the new standard is to get, for pregnant women, to get a pertussis shot when they're pregnant, so that some of that immunity goes to their baby, to help them be immune to it until we can actually give them their shots. But again, anybody who's taking care of the baby should have a pertussis shot so they don't give it to the baby. When we talk about the infant, we'll talk about care of the infant, but that's part of the discharge instructions as well, as far as feedings, what's normal for stools, cord care, and we'll discuss those discharge instructions when we talk about the newborn next week. And that ends this slide and this presentation on postpartum. Have a great day.